Good evening. I'm Nidhi Hegde, and welcome to a healthcare roundtable hosted by Fight Corporate Monopolies on this wonderful Monday evening. Fight Corporate Monopolies, we're an advocacy organization focused on addressing the problem of concentrated corporate power in our economy and holding public officials accountable to do so on behalf of consumers, workers, entrepreneurs, and small businesses. Well, it's no secret today that America's healthcare system is in critical condition. Despite healthcare spending approaching 20% of our GDP, the outcomes are poor. Patients are scrambling to fight for their care and face crushing out-of-pocket expenses. Healthcare workers struggle with worsening working conditions. Independent pharmacists are going out of business, and physicians have less control than ever over how they treat patients. And the root cause of all of these harms are monopolies. But there's some good news. In recent years, the Federal Trade Commission has prioritized ensuring a competitive healthcare marketplace. And today, we are fortunate to have with us two FTC commissioners, Commissioner Rebecca Slaughter and Commissioner Alvaro Bedoya, who have played a key role at the FTC to protect consumers from rising healthcare costs and to address the challenges faced by healthcare workers and pharmacists caused by consolidation. Along with former FTC Chair Lena Khan, they tackled anti-competitive practices head-on, such as challenging private equity roll-ups and anesthesiology practices, and scrutinizing pharmacy benefit managers, PBMs, for rebate schemes that inflated insulin prices. Their actions challenging improper Orange Book patent listings for drugs like asthma inhalers has helped bring down the cost for patients. And more recently, they joined current FTC Chair Andrew Ferguson to block a merger between the two largest manufacturers of critical medical device coatings. It goes without saying that Commissioners Slaughter and Bedoya are dedicated to enforcing the law to ensure that healthcare markets remain competitive and fair. While they are both currently in court fighting President Trump's attempt to fire them in violation of long-established federal law, that hasn't stopped them from continuing their work, which is listening to the public they serve. They have done this at open commission meetings held by the FTC and when visiting pharmacies and providers outside of Washington, D.C. So we're really honored to welcome them today to our healthcare roundtable as they continue listening and engaging with patients, pharmacists, physicians, and nurses. We have a fairly straightforward format, so I'm going to get out of the way. We'll first have some brief opening remarks from each of the commissioners and then hear directly from the various participants. So we have a lot of content. Thank you for joining us this Monday night. So with that, I will hand it over to Commissioner Slaughter.
Thank you, Nidhi. Thank you for organizing this really important roundtable. I have been an FTC commissioner for almost exactly 7 years, and among the most important opportunities and obligations I feel like we've had has been the ability to engage with members of the healthcare community who are on the ground telling us what they learn and what they understand about the way healthcare is working in practice, not just the way lawyers and economists try to sort of retrofit it for us, but hearing about real people's real life experiences. Former Chair Khan deserves enormous credit for her work to democratize the FTC and open the agency up to public comment and public participation through open meetings and various other fora. And I think what is really hits home for me right now is Commissioner Bedoya and I are dealing with a really unfortunate court battle over the role of the FTC is that the work that we're doing is not about us. It's about the people we're going to hear from tonight and their experiences on the ground in trying to deliver healthcare to Americans or access healthcare as Americans. There is nothing that is more important for people's ability to live a free and fair life than their ability to be healthy and to thrive. And so I'm really excited for this opportunity that you've put together for us, Nidhi. I think it is critically important. And I know Commissioner Bedoya and I are really joined at the hip in our commitment to making sure that all Americans have access to affordable, safe, accessible healthcare. And that is not something that either of us are going to take a pause on anytime soon. So with that, I'll pass it over to Commissioner Bedoya.
Thank you, Commissioner Slaughter. Thank you, Nidhi. Thank you, Fight Corporate Monopolies, for organizing this roundtable. I also want to thank each of our speakers. It's painful to say it, but unfortunately, the state of American healthcare I think is shameful and embarrassing, at least in the impact it has on regular people. I think it's shameful and embarrassing what happens when people get a cancer diagnosis, where they're forced to fundraise from friends and family, where so many of them go bankrupt. I think it's shameful and embarrassing that life expectancy in this country is years what it could be as compared to our economic peers abroad. It's even more shameful that low-income people living paycheck to paycheck, have even more years taken away from them. I think it's insignificant part due to the state of our healthcare system. I've been in this job working with Commissioner Slaughter, working with Chair Khan, former Chair Khan, for almost 3 years. And I have to say, at the end of that time, it's hard not to look at the system and see that at least some substantial part of those problems stems from concentration and consolidation in our healthcare industry, as well as the financialization of that industry, particularly the entry of private equity into so many critical markets. It's hard to look at what's happening to rural and urban pharmacy and not come to that conclusion. It's hard to look at the reports from patients and doctors and nurses from hospitals that have been taken over by certain private equity firms and not come to that conclusion. And so I think the work we're doing today is a continuation of that. For me, visiting doctors, patients, nurse groups across the country has been, I think, perhaps one of the most informative experiences I've had as a commissioner, and I'm really eager to continue that work tonight. So with all of that said, let me pass it back to you, Nidhi, so that we can start hearing from our speakers.
Great. Thank you so much. Our first speaker is going to be Mayank Amin, who's the owner of a pharmacy in Pennsylvania. Mayank, over to you.
Thank you, Nidhi, for the opportunity, and thanks for having me tonight to share our little story. So I own a small little pharmacy outside of the city of Philadelphia. I never intended to be a pharmacy owner. Ever since I graduated from college, I just wanted to do something to help patients, whether it was in our community or family members. And that stemmed out of my love for the community. One day I happened to be working a part-time shift at Walgreens, and I noticed a reader board sign outside the pharmacy that said, "Welcome, Skip Back Pharmacy patients." And I was confused because this pharmacy had been in our town for over 50 plus years. So there was no way that a pharmacy that has been around for that long would actually be shutting down just because of how famous it was in our local area. And I took a little drive over the next day and noticed a bunch of seniors standing outside what looked like a funeral. Patients were in absolute grief, trying to pull on the doors as they saw these red signs. And we all know the red signs, red correlates with a specific pharmacy that had just bought out the pharmacy that had been here for 50 years. People were absolutely torn, and I didn't really understand it because I'd truly never been into an independent pharmacy prior to owning one. That day, I decided that I was going to reopen this pharmacy. And as I was walking into the fire, other pharmacy owners thought I was absolutely nuts because they didn't know, why would someone actually open a business where you could potentially lose money for helping somebody? I actually didn't know that, so I'm actually glad I didn't know that. That might have changed my mind a little bit. And as my doors opened, we had a small grand opening, 50 plus people. And those patients in our parking lot had thanked me so much. One person rolled on the floor when we opened because they did not want to lose their independent pharmacy in their town. The red signs that I saw on the door soon turned into red streaks that I saw on my screen as I was typing prescriptions. Every day was a battle trying to get more patients into our pharmacy, but also seeing these red lines, which one day I called our software vendor and asked, "What are these red lines that I see on these screens?" And they said, "This means you're losing money filling that script." That was the first time in my life I realized that I was doing a job where I was losing money. But I didn't let that change anything because community pharmacies are here to try to work around troubles and to advocate for our patients in our community. And it happened to be around the time of COVID. So I decided, you know what, instead of focusing on prescriptions, I'm going to focus on toilet paper and sanitizer. And if you Google the word toilet paper or sanitizer in the Philadelphia area, we popped up #1. But that's not why I opened this pharmacy. That's not why patients wanted us to be here. They wanted us to be here to take care of their health. And we did absolutely whatever we could possibly do to get that. As I learned more and more, I started realizing as I was filling prescriptions, patients could get scripts with us 2 times. The third time, a message would pop up on our screen that said, "Sorry, this has to get filled at the local CVS pharmacy." These patients didn't want to go back there. They had just lost 50 years of care, and forced to go back to use that pharmacy. And now, once again, they were being forced to go back there. And we were left with a challenging situation of how are we going to continue to help these patients? That wasn't the only issue. As we were working through a lot of hurdles, we started noticing reject errors that would pop up that said brand required. So there's a cheaper generic medication available, for example, a cheaper inhaler that's available for patients, but the insurance company is requiring that patient who doesn't have money to get a brand name medication. Doesn't make any sense to me, and it never did, and it never will. In fact, for patients that are on Medicaid or Medicare, that's costing US tax dollars and Pennsylvania tax dollars even more, having to spend on patients that now have to get brand medications where a generic was available. COVID soon hit there afterwards, and regardless of patients' beliefs and whether they wanted the vaccine or not, we became a hub for COVID. In fact, our pharmacy provided over 100,000 vaccines in Pennsylvania. We turned into that center for hope for our patients, but once again, we started seeing hurdles. We would run a vaccine through someone's insurance, for example, a flu vaccine, and we'd get a rejection message that would say, vaccine admin fee not covered. And I'd try to Google what that meant because this was the first time I was seeing that. And to me, or any normal person, that would mean that the vaccine is covered, but the administration part where I have to pay a staff member to administer that vaccine is not. So I'm assuming the insurance company wants me to provide this vaccine, just give it to the patient, have them take it home or to their local CVS, and have that pharmacist inject them. Clearly not the case, but these are just some of the hurdles that we've faced. Now, the 100,000 patients that we vaccinated, there were over 1,000 patients, and even to this day, homebound patients who relied on us to give them vaccines. We don't get paid extra to go to someone's house to give them a vaccine. In fact, if we tried to bill one of the PBMs to give us a vaccine administration fee to go to someone's house, it would get rejected immediately. That thought has never entered our mind, although we would wish for it. Because during the pandemic and thereafterwards, oftentimes we as the owners have to go to patients' houses. It would start at 6 o'clock in the morning and end close to midnight, where we were going to people's houses because, in fact, there was no administration fee being provided for us to go to someone's house to give that fee, that vaccine. Now, that parking lot of 35 plus people when we had our grand opening turned into 1,300 plus people at our 5-year anniversary, which just passed last summer. We're going to continue to grow no matter what the obstacles and hurdles hit our way. We're going to continue to fight. We're going to continue to advocate for our patients because there are so many patients that rely on their independent pharmacies throughout the country. We're just one example, and we'll continue to fight the fight because our patients mean the world to us.
Mayank, if I can jump in, can you hear me? This is Alvaro. This is Commissioner Bedoya.
Hey, how you doing, Commissioner?
I'm good. I'm realizing hearing you that we have met before. We met just outside Philly at that roundtable about a year and a half ago. And let me ask you a very quick follow-up question. But first, let me just say that what you're talking about in terms of visiting homebound patients, one of the moments I remember from that roundtable we did with other pharmacists was I think I asked the room, hey, how many of you do delivery to the home? And everyone's hand shot up. And I think about that moment a lot when I think about the chain pharmacies that serve, suburbia and a lot of other areas, and how rare it is to see delivery there. And you're talking about visiting homebound patients. It just strikes a nerve, honestly, and about the difference in service you provide. One question for you, Mayank. We met maybe about a year and a half ago. How have things gone since then for your pharmacy? Have you been able to grow? Are you suffering greater losses? I'd love to get a sense of how things have gone since I first heard your story back then.
Sure. So you could say we're a pharmacy that in a short period of 5 years, we have over 100,000 patients in our system, which is not normal for any pharmacy to have. Yeah. I've never once asked those 100,000 people, would you like to transfer your prescription from CVS, for example, or a mail order to our pharmacy? I have such a fear that the day that I ask, we'll have to close our pharmacy down because we're going to provide them with the best service they've ever had in their lives. But there's a high chance that they might have brand name medications or medications that we lose money on. So for me, it's not worth the risk of providing medications to more patients. They know that we're the best at providing vaccines. We're the best at any kind of shortages that are going on. So we're kind of like we dressed up as superheroes during that time, but we fight crisis to crisis. And the question always arises, what if independent pharmacies aren't around? If there is a next pandemic or any kind of emergency situation, our state relied on us, our country relied on us, and I just don't know what would possibly happen in the event that independent pharmacies are not around if something bad were to happen. And our growth is not measured in the amount of prescriptions we fill. I will happily fill prescriptions and deliver prescriptions. And you mentioned the word deliver. I myself have two little kids, a 2 and 3-year-old. But the thing is that oftentimes the first year of my little child's life, he never got to see me because I was out making deliveries to people's houses at midnight because we can't afford to hire delivery drivers because we're not getting paid for it. So it's you either do it yourself as a charitable service or you lose money on it by hiring staff. So it's a tough situation that we face, but you can see that the love for our community and patients extends beyond the profit. We do this because we love our patients, not because of the paycheck.
Thank you so much, Mayank. And thank you for sharing all of this. I really appreciate it.
Thank you, Mayank. Next, we have Sheldon Birch, who is also a pharmacist from Utah.
Hello, commissioners. It's nice to be with you. It's an honor, really. I feel like the little guy here in this group. I'm just a guy from small town Utah with a couple of pharmacies. 21, 22 years ago, when I told my uncle, who was a clinical doctor of pharmacy, that I was going to go into a small town and work in an independent pharmacy, he did his darndest to try and talk me out of it and said, you'll never make it in a dispensing world. It's not going to last. Well, we're 22 years in and I'm doing my best to prove him wrong, but it's a difficult market that's getting more and more difficult all the time. We're in communities that support us and in areas where patients want the services that we provide, but it's just not a level playing field, as you all know. And we are relying heavily upon we need to rely heavily upon the help of the FTC in particular to try and help level the playing field. I had an experience just in the last few weeks where a fourth-year pharmacy student came to spend a few weeks with us at our location, and she had already decided that she was certainly not going to be in dispensing pharmacy nor in any other type of clinical care type of pharmacy. She had decided she was going to be in hospital administration, and she was planning to go on to do that as a career. And in the 6 weeks she spent with us, it was her only experience in a community pharmacy. And she said, by the end of the 6 weeks, she said, you know what? I'm almost thinking about changing my career path. I really enjoyed this. And she said, I enjoyed this because for the first time, I feel like I can do something and make a difference in someone's life. When I'm here at your pharmacy, I can see that there's a way for me to change what I need to change or to have control over my day-to-day activities in a way that I can have positive effects in people's lives. That's really what we do. And there's a number of people in this meeting who are all in the same boat. That's really what we do. Unfortunately, what we see right now in our marketplace, which is not a free market, is we see a massive transfer of wealth from Main Street to Wall Street. And it's a problem. And I'm a capitalist. I own businesses, right? But there has to be a point at which we need to get some help in order to have a playing field that is fair. And that is really my begging point would be help me make it through 10 more years in my career. Help me make this a business that my children will want to take over. Help keep small business alive. Help keep the dollars and cents on America's small town main streets. Thank you.
Thank you. Commissioner Slaughter, I don't want to hog the interim time, but if you have any reactions, you should go ahead. Otherwise, I'll say
No, I think it's an incredibly compelling story, Mr. Birch. I hear what you all are saying in terms of your motivation to serve your community with quality of care. And I think the point that you made about the transfer of wealth from Main Street to Wall Street is the one that really resonates for me in the law that we are tasked with enforcing, because the law does not contemplate that. That is not what the law was designed to protect. And so as a human who requires medical services, who has 4 children who require medical services, I'm personally moved by what you're saying. But I also think that as a government official, I think a lot about how the experiences that you are describing are not what the law was designed to protect. And so it just makes me spin about what are the ways in which government intervention is appropriate to protect the services that you are wanting to provide to your fellow Americans, so that they can have the quality of life and quality of health that people should have in the richest country in the world.
Well, if I may respond just briefly, I'm so thankful for the FTC's work in recent years of the investigating the PBM market, and that's as we're now seeing some effect from that. I believe we're seeing PBMs who are bringing out new pricing models that they're claiming are for everyone's benefit. In reality, I think it's probably due to the work started by you folks, you commissioners at the FTC, and it's very much appreciated. And I hope we can continue that investigation.
Yeah, the only other thing I'd add is what I'm hearing when I listen to what you're saying is that this is not a partisan issue. Nobody is talking about Democrats or Republicans. Partisanship really does not discriminate in terms of the need to access quality healthcare and the challenge in doing so. And I appreciate that the focus on this conversation is not on which party is better equipped and better planning to address these problems, but what are the problems and how can we, across party lines, figure out what solutions are necessary. I think that's exactly why we should have bipartisan agencies that can address these things. But I think it's a really, compelling point.
Well, thank you, Sheldon. Next up, we have Loretta Boesing, who's the founder of Unite for Safe Medications. Loretta.
Thank you so much for the dedication to addressing the monopolization in healthcare. My son was 2 years old when he had a life-saving organ transplant. He now relies on medications every 12 hours without fail. His future, like many other children and patients, now depend on access to these medications in pharmacies. In 2018, I became an advocate after realizing the failure of agencies and state boards of pharmacies, legislators to protect patients. Many were turning a blind eye while the PBMs and the insurance companies grew stronger in forcing patients like my son to use understaffed retail pharmacies or pharmacies that were not only inconvenient but dangerous. There were delays, interruptions in treatment, and PBM's mail-order pharmacies, they send most meds in flimsy bags, exposing them to extreme temperatures that no parent would ever want to expose their child's meds to, nor, unlike billion-dollar corporate pharmacies, would they ever get away with it. And today, parents and patients are forced to because patients receive these demanding letters that they must use mail-order pharmacies or face the full cost of their medications. These letters, they feel like such a betrayal of everything that we stand for in this country, trapping Americans in a broken, monopolized system. There's still no clear protection for patients on many of these issues. The FTC study named one of my son's meds, and it confirmed what I had saw. When we were forced to use the PBM's mail order pharmacy, the PBMs reimbursed their own mail order pharmacy over 10 times what they reimbursed the local pharmacy. It's price gouging behind a misleading lower copay. We, patients and taxpayers, we end up paying the price through rising premiums and tax dollars, while they profit billions. But then there was hope. Thanks to Chair Khan and FTC commissioners' bipartisan efforts in Congress, there has been an effort to address the monopolization. The FTC, once dormant on these issues, is taking action, and finally my family and thousands across the nation are starting to breathe a sigh of relief. Our nation needs to see it through, and that this monopolization will be stopped by our federal government and agencies. Daily, more children and patients are denied access to life-saving medications, they're forced to risk delays, and many other issues. Elderly patients are forced to travel miles to find a pharmacy. Some, they're just giving up, that I've spoken with, they're giving up and they just stop taking their meds. And as the PBMs cause closures of their local pharmacies in rural and urban areas that need them, it's a sad situation. So I'm just asking anyone that's listening to please keep fighting. The FTC, the new chair, please uphold the antitrust laws, and everyone just keep uniting for this cause. Thank you so much to the commissioners here today for the progress that you've made and the hope that you have given. Thank you.
Thank you so much, Loretta. Thank you, Ms. Boesing. I will add a detail here that is in line with what Commissioner Slaughter just said, which was the interim report you cited was a 5-0 vote. You know, this was a unanimous vote of the commission to get this information out there. And so, you know, whatever you do here about Washington and you know, some of the specific situations we find ourselves in today, my hope is that we can get back to normal and continue pushing this work forward. I will also add another thing I've heard in a roundtable like this one, I think this one was in Knoxville, was that some of the compliance measures for pharmacies differ between mail order and brick and mortar, so that mail order pharmacies can kind of check off patient is complying if the medicine is delivered to the home, whether or not there's someone there that actually picks it up. It may just be sitting on someone's porch, maybe sitting on the wrong porch. It may be degraded as a result of the heat that you mentioned or the extreme temperatures, whereas the brick and mortar pharmacies, the compliance measure is fulfilled when the person actually shows up and picks it up, which yes, it does show compliance, but it isn't parallel to dropping it off at someone's home. And I think the allegation is that this preferences the mail order pharmacies, which are owned by the PBMs. That was something else that jumped out at me. But Ms. Boesing, thank you for your work. Thank you for advocacy. I've followed it for some time, and I hope to continue to do so.
Thank you. I definitely will. I will not give up. You don't have an option when it's your child's life, and after connecting with so many other patients who are truly suffering. I just want to add too that these local pharmacies, if I want to get my son's medications delivered because our whole house is sick and it's just better for us at that time, they will deliver in a temperature controlled vehicle at a scheduled time. You do not get that level of care from these big mail order pharmacies that would just leave it out in a hot mailbox in the middle of the summer or freezing in the winter. So thank you again so much. And we need to keep this bipartisan. And I truly hope that it will remain a bipartisan effort.
Me too. Thank you.
And I just want to jump in to compliment you, Ms. Boesing, because you have personally alerted me to things I had no idea about in the healthcare system. I didn't hear about from pharmacies. I didn't hear about from lawyers. I didn't hear about from economists. But your personal advocacy has reached me. And I just want you to know that it matters. I know you're doing it for your son and for the millions of other people out there like your son, but I know how hard it is when you are trying to be a mom and take care of your kids to also spend your time advocating for other people's kids and for the system. And so I just want you to know that it matters and it's working and that I hear it and it really has, you personally have educated me an enormous amount, and I'm so grateful for your work.
Thank you so much. That means a lot to me. And I'm sorry at first. I know I reached out to you. I think on Twitter, I would continuously tweet like, hey, why isn't this working? You know, this system, why is it so broken? And just thank you for that. And those comments is very kind. And I will continue.
Thank you, Loretta. Next up, we have Dr. Kathy Campbell, who's also a pharmacy owner all the way from Oklahoma.
Yes, thank you for having me tonight. It's a real privilege. My name is Dr. Kathy Campbell, and I am a clinical wellness pharmacist, an independent pharmacy owner, and have for 33 years served 4 generations of patients in my town of Owasso, Oklahoma. I want to thank you for this opportunity to share my perspective. The perspective is the voice of the community pharmacist, a trusted partner in health who sees firsthand the consequences of a healthcare systematic shift from a relation-based model to that of a model based on corporately manipulated transactions. For decades, community pharmacists have provided a critical health infrastructure. We provide daily, easily accessed acute care, optimize therapies in real time, and triage early warning signs of serious conditions. We know our patients, we know their families, and they trust us. These relationships are not just a business model. They are the essence of human care itself. As a pharmacist, I have a moral, legal, and ethical responsibility to best take care of my patients. I take this oath and privilege very seriously and work diligently to assist my patients in not needing medications and to ensure my patients have optimal health and lead long and vital lives. This traditional model of care is being decimated by the large corporate entities and pharmacy benefit managers. They have established these monopolistic controls over the transactions of healthcare, drug pricing, insurance networks, reimbursement models, and consumers' lives. They dictate which medications can be accessed, where they can fill them, all while imposing take it or leave it provider payment rates below product acquisition costs. No pharmacy, no business can financially survive this indentured model, as proven by the record numbers of community pharmacy closures and the current dismantling of this critical healthcare infrastructure. The CEO and the accountants of these monopolies manipulating these healthcare dollars do not have patience. They have not sworn this oath of patient care. Instead of providing quality care to patients, they measure their success based on the balance sheet and shareholder profitability. Within this transactional system, they are not held accountable for the damages that they inflict to patients or providers. To them, patient suffering is the cost of doing business. For patients, the impact of this corporate manipulation is catastrophic. Corporations are increasingly extracting the healthcare provider, in our case, the medication expert, the pharmacist, from the patient's healthcare team. The pharmacist who knows their therapeutic history and is the chemistry expert is replaced by automatic call centers and dangerous mail order mandates. Vital therapeutic decisions are now made by algorithms rather than the clinicians who actually know and care for the unique patient. Worse than the transactional model, the transactional model incentivizes quantity of transactions over therapeutic quality, reducing patients to mere diagnosis codes or profit margins. This system incentivizes disease production over disease prevention. The human cost is undeniable. Chronic health conditions are threatening the future of our country. More than 55% of American children and adults suffer with a chronic disease. The impact of excessive and unmonitored medication use now contributes to the third most common cause of death. While most of these issues are preventable, these corporate monopolies ensure that few resources are available to truly prevent disease. In my own practice, I fight to provide proactive care to my patients in the face of a corporate business practice that thrives on their suffering and works daily for my extinction. I am here tonight to not just as a business owner, but as that pharmacist and a mother fighting for our grandchildren's right to be born into a world that allows them to be healthy. We need the FTC to continue to take bold and urgent actions, demanding that transparency and regulation of PBM practices and pricing structures, as well as the rigorous enforcement of antitrust regulations to prevent further consolidation. As a community wellness pharmacist and my patient's chemistry expert for the last 33 years, I've learned a couple things. I've come to realize that the most impactful chemistry we have to facilitate human health is love. Independent pharmacy is the last remaining guardian of this relationship-based healthcare and dispenses love daily within our communities. I implore those listening to protect and support the critical public health infrastructure of the independent pharmacy and severely regulate those entities monopolizing and destroying this healthcare. Thank you.
Thank you, Kathy. Next up, we're going to have Carmen Comsti, who is with the National Nurses United. She's a lead regulatory policy specialist with them.
Thank you. And thank you, Commissioners Bedoya and Slaughter, for your ongoing commitment to the work of the FTC. I'm Carmen Comsti with the National Nurses United, the largest labor union of registered nurses in the country. NNU nurses have seen the devastation that results when healthcare corporations amass economic power in pursuit of profit. And it's not just that healthcare systems are pursuing market control, it's what they are doing to our communities with that power. Take the example of Mission Healthcare in Asheville, North Carolina, when HCA, the country's largest and wealthiest hospital corporation, bought Mission in 2019. Before HCA, Mission was a source of pride in Western North Carolina, well known for excellence in cardiovascular, pediatric, and neurotrauma care. But HCA almost immediately started to cut services. The rural cancer center, the wheelchair clinic, primary care clinics were shuttered. As services closed, vulnerable rural patients were forced to drive over an hour for needed care to other HCA facilities that could charge more for services. HCA also took its hatchet to charity care, geriatric services, security, and even hospital chaplains. Staffing at the hospital was dramatically cut. Nurses, doctors, support staff, all cut. And as one of the only healthcare employers left in the region, HCA has the power to force cost cutting on the backs of workers and patients' health and safety. HCA has been able to use exploitative contracts to force nurses to continue working in unsafe and unfair working conditions, or else pay for on-the-job training if they leave for better jobs. In the trauma center, staffing levels dangerously decreased from one nurse to every 3 patients to only one nurse for every 7 patients, meaning that trauma nurses can only spend 8 minutes per patient per hour. Nursing under these circumstances is more like factory work than high-quality patient care. A former shell of itself after the merger, quality of care at Mission dropped, but healthcare prices shot up 10%. Patients reported aggressive billing practices by HCA's in-house debt collection firm. The state attorney general recently sued HCA when care in the emergency room and cancer center deteriorated with long wait times and consistent understaffing. What was HCA's response? They said that they never committed to providing quality care at Mission when they bought it. Unfortunately, what's happening at Mission is part of an alarming trend of healthcare systems buying up competitors only to close and reduce services that they deem to be less profitable. This is a form of medical redlining where healthcare conglomerates avoid low-income areas and communities of color who may bring in lower returns. This results in healthcare deserts in rural and underserved areas, perpetuating systemic racism and income inequality. As health systems gain larger and larger market power, they become less and less accountable to patients, workers, and our communities. We must have a strong and effective FTC because our lives and livelihoods are at stake. Thank you so much.
I just wanted to jump in and say thank you, Carmen, for sharing all of this. And I read about, I think, the hospital you're mentioning and the change in staffing levels and the impact that has, and it was just horrific to read about. And so I would love to stay in touch. I'm sure Commissioner Slaughter feels the same way. I was about to say, give you my FTC email. I cannot give you that, but we will figure out a way. I will work with the folks hosting this, Nidhi and crew, to make sure you get my contact information. The same goes for all the other panelists as well. But thank you.
Yeah, I agree. And I particularly appreciate you surfacing the ways in which these kinds of consolidations can result in disparate care, particularly for marginalized and underrepresented communities, which is, I think, something we're not supposed to be talking about today, but it is actually real and important, and really important. And it is communities of color in urban areas. It is rural communities. It is all of the areas where healthcare needs are greatest and money and profits are the least available, and they're the first to get cut. The FTC blocked an HCA merger in 2022 that I think was a really important action. But obviously, I think about some companies in my head, I call them frequent flyers, ones we see again and again and again, because they're particularly acquisitive. And we can address one acquisition, but it doesn't address the pattern, which is why I think the work that the FTC has been doing over the last several years to address serial acquisitions, including by private equity corporations and other for-profit healthcare entities, is particularly important. It may feel very in the weeds, but when I hear the stories that you're telling, it resonates with me about some of this very detail-oriented work that we have been doing to interrupt patterns in the market that have hugely detrimental effects. So I really appreciate you raising those stories, and I think that they really resonate to me with a lot of the patterns I have seen over the time of our work.
Thank you so much, Carmen. Next up, we have Dr. Mitchell Goldstein, who's a professor of pediatrics at Loma Linda University School of Medicine and the chairman of Physicians Against Drug Shortages.
Thank you. I'm sorry, can you hear me?
Yes, we can hear you.
Okay, very good. So the Physicians Against Drug Shortage is an organization that has been dedicated to ending chronic shortages of essential generic drugs by addressing what we believe are the root causes of market failures in the healthcare supply chain. We were founded in 2012, and since that time, we've challenged the prevailing explanation that drug shortages are quote-unquote complex and quote-unquote multifactorial. Instead, we've identified the anti-competitive practices of hospital group purchasing organizations, including GPOs, group purchasing organizations, and PBMs, pharmacy benefit managers, as the primary cause. Our organization is comprised largely of those professions who are most affected by this, including critical care specialists like myself as a neonatologist, and as well anesthesiologists and adult critical care specialists. We are deeply concerned about the impacts of these shortages on patient care, particularly regarding sterile injectables, chemotherapies, generic mineral solutions, and anesthetics used in hospitals and clinics. The kickbacks, which have been allowed through a safe harbor exemption, create market manipulation and monopolistic practices within the GPO industry that have disrupted the supply chain, leading to preventable patient suffering and deaths. We have worked to raise awareness through mainstream and social media, including a pivotal 2013 New York Times op-ed, How a Cabal Keeps Generics Scarce, and a 2022 60-minute special discussing medical middlemen, broken systems making it harder for hospitals and patients to get some life-saving drugs. Our advocacy has led to increased recognition from the FDA and the GAO, both of whom have acknowledged GPOs as a key factor in drug shortages. Notably, our organization operates without external funding or conflicts of interest, with our members volunteering our time and resources. We seek public support and congressional action to reform the system and restore integrity to the generic drug marketplace. We welcome new members and allies to our effort. Thank you.
Thank you, Doctor. I will just say one of the things that I've proposed to Chairman Ferguson that we do is engage in once the current PBM market study finishes, that we proceed to a subsequent market study focused on drug shortages specifically, and to try to study some of the problems that you and your organization have highlighted. And so that is something that I hope one day we can turn to, and not a day in the too distant future. So that's something I'm proposed. Yeah, please go ahead.
Yeah, the hardest thing for people to understand is, although these kickbacks are very, I guess you could say, essential, as certain hospital administrators may describe it in terms of running their hospital, and the perception is that they decrease costs, there is that middleman, and the middleman has to be paid. And as these incentives continue to squeeze medical manufacturers, the numbers of medical manufacturers continue to decrease. So what we have is a race to the bottom. And when we start looking at serious shortages, like that situation where the hurricane knocked out the entire nation's supply of sterile normal saline, these are the sorts of things that imperil our population, but also wind up benefiting nobody. Because again, if you don't have the supplies, you can't get it.
I just want to say, I really appreciate your calling out the tendency of people to say, oh, this is too complicated and opaque, we can't possibly address it. And the sort of clear-headed, straightforward willingness to say, no, it's not that complicated. It's actually like, here are the issues where it comes from. I find that all the time, that people say, oh, no, it's very complicated. You can't possibly address it because it's too complicated. And sometimes it's actually not that complicated. And also, I think a lot about one of my kids' kindergarten teachers had a saying, which is kindergartners can do hard things. And I think, and that's true. And if kindergartners can do hard things, so too can government officials, medical professionals, even lawyers can do hard things, which is figure out how to solve these complicated problems. I've been on the receiving end of drug shortages where there weren't adequate pain medications after I had surgery one time. And that is a really, really hard thing to deal with. And it is absolutely critical to address. And if we do not have the kind of robust resilience in our supply chain and our medical production system, it's not going to go away. And what we have seen is that as we have consolidation and concentration in these supply chains, that creates a resiliency problem. If there is a failure in one area, it is we don't have the capacity to compensate, and that is something that causes everybody to suffer. So I really appreciate you elevating these issues.
Yes, the lack of transparency is the problem. And when people understand how simple it is and how, I guess you could say, directed it is from a standpoint of where these costs are going, essentially we are paying into a system to create the shortages that we're most concerned about.
Thank you so much, Dr. Mitchell Goldstein, for that perspective. We've really heard from a wide range of folks today already, from like pharmacists, from physicians, patient advocates. Now we've also heard about like shortages, but stay tuned. We still have a couple more speakers. Next up, we have Deb Keaveny, who's the owner of a pharmacy and also a plaintiff in a class action lawsuit against the two largest PBMs. So we're here. So take it away, Deb.
Thank you. Good evening, and thanks for this opportunity. My name is Deborah Keaveny. I'm the owner of Keaveny Drug in Winstead, Minnesota. I'm also the president of Pharmacists United for Truth and Transparency and the founder of Minnesota Independent Pharmacists. The experiences of my store are not different than the ones that you've heard tonight. We just want to thank you for your unwavering commitment in exposing and addressing the PBM abuses that harm patients, independent pharmacies, and undermine the healthcare system. Your dedication to fair competition and consumer protection has been critical in the fight for lower drug costs and independent pharmacy sustainability. You both have championed the rights of patients and independent pharmacists, working to stop PBM practices that drive up prescription costs and force pharmacies out of business. Your efforts have ensured that patients, especially in rural, underserved areas, can continue to access essential medications and care for their trusted local pharmacies. We are deeply concerned at the administration's recent decision. Americans need reassurance that the FTC can and will stop anti-competitive practices in the corporate monopolization of healthcare. This is not a partisan issue, and your removal can put ongoing studies, investigations, and actions in jeopardy and can lead to weakened enforcement and protect the PBMs from much needed scrutiny. The FTC must continue your work. We need the independent oversight and accountability the FTC brings, stopping prioritization of corporate interests over the needs of patients and pharmacies. We must push back against efforts to dismantle regulatory efforts that seek to make drug pricing fair and more transparent. I have worked with the FTC for several years, sending evidence exposing these PBM practices. Legislative remedies are slow and can be tainted by industry influences, making enforcement bodies like the FTC crucial. Litigation is another avenue to enforcement, and that's why class action lawsuits are necessary and ongoing. We urge lawmakers, advocacy groups, and the public to stand up against the unjust decision and ask the FTC to continue its vital work in reining in PBM abuses. You both are to be commended for your commitment to fairness, transparency, and consumer protection. We thank you.
Thank you, Ms. Keaveny. I appreciate that.
Thank you. Next up, we have Dr. Ed Weisbart, who's the National Board Secretary and Missouri Chapter Chair for Physicians for a National Health Program.
Great discussion. The more you need healthcare, the more you need a physician whom you can trust, somebody who puts your health above any other priorities. And that was my job for more than 40 years. I'm Dr. Ed Weisbart, and I say this as the Board Secretary of Physicians for a National Health Program, a nonpartisan organization of 26,000 physicians and others who support Medicare for all. We say that because we believe everyone deserves access to high-quality health care of their own choosing, free of deductibles and copays and conflicts of interests. But I also say this as a retired family physician who took care of tens of thousands of patients, took care of them in my office and in the hospital, helped them through births and deaths, and I loved that work. There were a lot of tough times, like breaking the news that somebody's emphysema was going to just continue to get worse or that their cancer had come back. But a stable doctor-patient relationship helped me gain their trust and ease their pain, if just a little. Those tough times were balanced by a patient, for example, whom I met with a hypertensive emergency when I was on ICU call. I became his primary care doc and followed him in my office for the next 15 years. And proudly watched him not have a stroke and not have a heart attack and not need dialysis because he trusted me enough to stay on his blood pressure meds. And it was a terribly sad moment when he told me that this was going to be his last visit with me because his employer switched insurance companies and I was no longer on their list. This corporate-driven fragmentation of healthcare has become the norm in America. 3 out of 4 physicians are now employed by a hospital or a health insurer or a private equity firm or some other corporate entity, disrupting any patient relationships that don't serve the interests of the corporation. This makes sense for hospitalists, but it creates perverse incentives for primary care doctors like me. Physicians are being increasingly forced to assume financial risk, intruding on patient care, rewarded for keeping our patients inside the corporation's network, punished when we attract sicker patients, and undermining our patients' ability to just trust our advice. Allowing corporate priorities into patient care violates our medical ethics. When an insurance company tells us to prescribe a less effective treatment, profit motives have infected the standard of care. The most elegant solution, of course, is to improve Medicare and provide that to everybody. But that's a bit beyond the FTC's purview. But we share the concerns about the damage of unchecked corporate greed on American healthcare, and unchecked corporatization is in FTC's wheelhouse. Thank you so much for fighting for all of us.
Thank you so much, Dr. Weisbart.
And I just want to thank you for your advocacy for your patients. I think you are making plain what I have seen in my own life. I think there's a sort of cultural myth that people go into medicine to get rich. And it is, my brother is a doctor, my father is a doctor, my father-in-law is a doctor. I have nurses in my family. I know and love pharmacists. I don't know any of those people who do their jobs to get rich. I know that they do it to serve their communities. And in fact, they're really hard jobs that involve a lot of struggle and service. And what I just heard and what you were saying is that commitment to service on behalf of your patients and to their health care, life care. And I think it's really important and really admirable and really difficult to accomplish in a system that prioritizes profit over patients. I don't think the law prioritizes profit over patients in the way that the system does right now. And so our job in the administration of the laws is to make sure that the focus is on what Congress intended, which is making sure that there is free and fair competition for the best quality of service, the best prices, the best opportunities, the best access. And I appreciate your highlighting the ways in which that is not playing out in reality.
I think the only other thing I would offer is one area of valuable pushback has been state level prohibitions against the corporate practice of medicine. What basically laws requiring that it be a physician that be the owner of a hospital or a medical practice. And unfortunately, in some states, we've seen that those laws either fall away or we've seen private equity firms skirt around them through some very creative legal work, shall we say. And so, you hit this, I think Dr. Campbell hit this, so many other people have talked about how that patient-doctor, patient-pharmacist relationship is a special one, and one that we need to value, and that too often is just left by the wayside in some of these corporate moves and consolidation. So I really appreciate what you're saying, Dr. Weisbart, like Commissioner Slaughter. Thank you.
Thank you.
Thank you, Dr. Weisbart. So our last speaker is Dr. Neal Smoller, who is the owner of a pharmacy from New York. Neal, over to you.
Speaking of working after hours for no pay for your people, thank you both for being here.
Thank you.
You're almost pharmacist, I would say, right? So I have an 82-year-old patient named Jim. Despite his age, he's active, he volunteers, and he's fit. He came to me and told me that he has 4 days to live. He was just diagnosed with bowel ischemia. He was in horrible pain. He couldn't hold food down. But he wants to be home and he wants to feel better. He's in my store. He's with his son. And you can see the fear and the worry in both of their faces. They just don't know what to do. His pain management orders from the hospital had problems all over it. So I did what I've always done. I listened and I gave him my entire focus. I taught him how to calm his stomach with food. I gave him a nutrition plan. I spent 2 hours of my own time after hours contacting hospitals, his doctor's on-call service, and even 5 other pharmacies to solve his pain management problem for a prescription that if I filled, I'd be reimbursed 40 cents over my cost from his PBM. 40 cents to dispense one of the most dangerous drugs on the market, concentrated morphine, after I spent all that time fixing problems that weren't caused by me. So all that resolved and Jim implemented my plan. And after a few days, he walked back in to see me, this time with color in his face and a big smile. He followed my food recommendations. The pain had stopped without needing much of the pain medicine at all. And he has energy now. And that was 2 months ago. He's still here with us. He says to everyone that he meets, not only did my advice give him more days, but better ones. And my story about Jim is certainly special, but it's not unique. There's thousands and thousands of us that want to do that work every day, but we can't. They've been driven out of business because of our broken pathological reimbursement system. In my community, if I didn't exist, if my business did not exist, there are, without exaggeration, tens of thousands of stories of Jims that my team and I are responsible for that would not have never happened. And despite our successful stories and our high regard in the community, we probably can't survive. The only reason we may not exist, the only reason that many of us don't exist any longer is the monopolistic practices of PBMs. Not because of our own mismanagement and not because we're too small, it's PBMs. The monopolistic practice of PBMs are theft. They steal money from patients, from providers, from payers. Our care gives people better days. It saves the days and it saves lives. PBMs steal money and they steal the extra better days that we can give people. And they steal the longer, healthier lives that people can have because of our expertise and accessibility in our communities. And that's why I support you guys. I support the meaningful reform that you guys have tried to implement. And I think you should be reinstated to get your work done.
Thank you.
Thank you. I was just going to say, thank you so much, Dr. Smoller. I appreciate that vote of confidence, but more importantly, for me, there's a story that I've told at a couple of gatherings like this, which was my introduction to this really, I don't want to describe this world of community pharmacy where I was online trying to learn more about this acronym soup that is, PBMs, GPOs, NADAC, WAC, et cetera. And I came across the story of this West Virginia pharmacy where a family walked in, their kid had cancer, and they had the prescription in their hand, gave it to the pharmacist. Pharmacist said, "I have it," but then the screen popped up and it said, "No, the patient has to go home and get it from the mail order pharmacy." Now that's usually how I tell the story, but I leave out one detail, which, well, I usually say they got the medicine, but what I leave out is that it took the pharmacist 2 hours on the phone, not just with the PBM, but with the state insurance commissioner, to be able to dispense the drug to that patient. And I think it's a real testament to the relationships you have with your patients, the value of care you provide to them. And it's a recurrent theme in pretty much any gathering like this that comes up. So I'm very grateful to you, to the work you do, that above and beyond service that absolutely makes a difference in your patients' lives. So thank you.
And maybe I'll just finish by echoing Commissioner Bedoya's thanks to you. I am very inspired by your refusal to stop fighting for your patients. And I just want to say to you and to everyone else here that I am confident Commissioner Bedoya and I share the same commitment that we will not stop fighting for these issues that we care about and the work that we think needs to be done to make healthcare more accessible, more affordable, and more fair for Americans. It is, you guys are on the ground every day and you're seeing it in the real world and you're fighting for real people. And I just want you to know that we have your backs and we are right there with you in this fight and deeply, deeply committed to making sure that all Americans have access to pharmacies, access to pharmaceuticals, access to the healthcare that they need and deserve, again, in the richest country in the world. This should not be hard, and we can make it happen.
Thank you.
Thank you so much, Neal, and thank you to everyone who has, made the time to join us today. We've had like several thousand people follow us along on like Twitter and YouTube, and it's 9 p.m. on the East Coast on a Monday night. So I think that demonstrates how important this issue is in our economy. And as we've heard again and again from the speakers and from the commissioners, this is an issue that is not tied to any particular political party. And every account you heard here today shows that healthcare is not just numbers on a spreadsheet or chemical formulations and devices, which is how monopolies see us, but it's about people. And the people who spoke today showed a lot of courage to share their accounts. So thank you so much for the work you do, serving your patients and communities and fighting for all of us. And thank you so much, Commissioners Slaughter and Bedoya, for your continued dedication to this work and for listening to us. Just as you have had our back, when you've been in the commission, you should know that this community also has your back, and we are looking forward to you being back at work very soon, since there is so much to be done. For everyone else joining us, if you're interested in being part of the fight against monopolies in healthcare, please join the initiative started by our sister organization called Break Up Big Medicine. And lastly, I just want to give a shout out, because this is like a late night programming, to my colleagues, Benjamin Jolly, who's also a pharmacist himself, Emma Freer, Lily Solomon, and Jimmy Wydurko, who really helped us put this all together, as well as ACT TV. So thank you for joining us, everyone.